Hi, everyone, and welcome to Agoraphobia and Germaphobia in COVID-19. A few housekeeping items. Today's session is being recorded. The slides and recording will be sent out to all participants following the meeting. We do not offer CEUs. However, you can get information regarding how to receive a certificate of attendance in the same email with the slides and the recording. Please use the chat box or the Q&A function to ask any questions that you have. And all participants are muted on entry and unable to turn their microphones back on. Today's panelists are Karen Lynn Cassidy. She is a lively sought-after speaker and commentator on national media such as Nightline, The Today Show, Animal Planet, The Joy Behar Show, Huffington Post, Public Radio, and many more. She is the past president of the Anxiety and Depression Association of America and the founder of Anxiety Treatment Center of Greater Chicago and Moms Without Worry, a program that helps mothers overcome overwhelming and the cultural pressure to be perfect and raise the perfect kids. She hosts the Mom Without Worry radio show. She is a certified trainer in the Academy of Cognitive Therapy, a clinical fellow of the Anxiety and Depression Association of America, a founding fellow in the Academy of Cognitive Therapy, and a winner of the prestigious Clinician of Distinction Award from the Anxiety and Depression Association of America. She has numerous scientific publications in the area of anxiety disorders. She enjoys using her expertise to help patients and therapists overcome anxiety and mood disorders. She especially enjoys helping people become their better selves with authenticity, joy, and good humor. Keith Bredemir is an associate professor and director of research training at the Center for Treatment and Study of Anxiety. Dr. Bredemir received his Bachelor's of Arts in Psychology at the University of Delaware and his doctoral degree in clinical community psychology at the University of Illinois, Urbana-Champaign. In graduate school, his research focused on risk factors for emotional difficulties with a particular focus on cognitive factors associated with anxiety and depression. He completed his pre-doctoral internship at Brown University, followed by postdoctoral fellowships focused on suicide risk and prevention in the Department of Psychological Research at Brown and the Aaron T. Beck Psychopathology Research Center at Penn. Dr. Bredemir's current research focuses on cognitive traits and difficulties involved in the etiology and treatment of transdiagnostic dimensions of anxiety. For example, excessive worrying, repeated negative thinking, rumination, and related problems, depression, suicidal behavior. He specializes in cognitive behavioral therapy for anxiety disorders, including exposure and response prevention for obsessive compulsive disorder, prolonged exposure for post-traumatic stress disorder, and CBT for generalized anxiety disorder and social phobia. With that, I'm going to hand it over to Dr. Cassidy.
Hi, everyone. Let's go to the first slide, Madeline. So I'm going to ask you all a question. Of these two images, which one grabbed your attention first? If you're like research suggests, it's going to be the skull and crossbones, even though that beautiful mountain image is one that we would all enjoy and relate to. And this illustrates one of the problems that we all have to deal with when we're living in a time of heightened awareness of medical danger in the pandemic, and that is our minds are hardwired to pay attention to threat and to negative information. And scientists speculate that this is probably something that was very advantageous to us as we evolved as a species. It would give us the advantage in survival. Our dilemma is that, we no longer find that terribly useful. And in fact, it's something that stacks the deck against us in terms of our own mental wellness. And it's really tough. And unless you do work to change your focus from always noticing threat and negative information first, then you're going to be more susceptible to developing problems with anxiety and depression or other mental health dilemmas. And I'm going to be talking about that later on, and Keith is also going to be talking about what you can do to change that. Another problem that we have is we know that the kind of news that sells and grabs attention plays with this bias of our mind. We know sensationalistic, scary, exciting headlines grab our attention. And then also we know that the algorithms that social media uses, that Google uses, that the various search engines use, is that it feeds you more information like the stuff you've already seen. And so if you click open on that scary headline about, millions likely to die from world pandemic, economy likely to crash, then you're going to get more headlines like that as opposed to the good news headlines or the happy news headlines. And so that also changes our public misperception. And in fact, one thing I'm going to ask all of you, a little pop quiz question, is what has happened to the rates of interpersonal violence over the past 40 years? Are we more likely to have children who are sexually assaulted, taken advantage of, or are women or other people more likely to be hurt in interpersonal violence? And if you answered anything other than our rates are the lowest they've been in 40 years, then you are a victim of this bias in the media. And so what's happened is we now perceive the world as a more dangerous place. And when we do large general surveys of the public population, they vastly overestimate the amount of harm that is going on, when in fact, many of the societal measures that we've taken, some of which you are probably part of in terms of public health campaigns, public safety campaigns, decreasing risk factors, have been working very well. The other thing research says is you're going to be more likely to remember this skull and crossbones image more than any other slide that Keith and I will show you, unless you've done something to change the bias in your mind. So let's go to the second slide. So how many of you have gotten righteously mad during this past 4 months here, 4 or 5 months? And I'm going to guess you're on one of these two sides. You're either the righteous mask wearers who are getting angry at the people who are not wearing masks, or the people who are feeling like their rights are infringed. I live in the state of Wisconsin where, it's the right to die people, as we call them jokingly in my household. People won, and we didn't have to wear masks until recently. And this is part of the fight response. And I'm sure you've heard this from your undergraduate days, that we have the fight, flight, or freeze response when there is threat. And the dilemma with the fight response is that fear and anger activate us, and they get us angry. And unfortunately, when we get angry, then we're only able to recall information that justifies that anger. We selectively pick out information in the environment that justifies that anger, our fear, justifies our fear about how dangerous those non-mask wearers are, or how, tyrannical those people are who force us to wear masks, et cetera, et cetera. And then the dilemma with that is it can play into anxiety, and it can make it easier for us to get stuck when we're not realizing that we're just automatically going into this fight or flight response, as opposed to taking a reasoned response where we realize we need to be tolerant. We each have personal levels of risk-taking and professional responsibilities for how we manage risk and safety from COVID. And that all of these responses have their role and need to be tolerated, because no two of us is exactly alike. And so that's something that can play into fear. And then in the next slide, I want to ask how many of you have gotten stuck in indecision, okay, in this freeze response. If you can see in the slide, the fighter's going fight or flight, fight or fight, flight or flight. And one thing that I saw with a lot of my patients and some of my friends at the start of the pandemic is just not knowing what to do, who to listen to, what to follow, even though normally these people, and you may have been one of them, where you're very capable, you're well trained, and just feeling stuck. And this is something where people can get stuck in this getting stuck, where they keep saying, I can't trust any source of information. No one has anything useful to say. I can't trust anyone. And then one thing you need to know that this is not an unusual response. If you do post-mortems of disasters or sinkings of ferries or the Titanic, you find that people being quiet and not moving is actually the most common response that people do when there is a crisis. And contrary to the movie image of everybody running around or running amok, you see people just knowing not what to do. And this can be very difficult to manage because the other people who are in the flight response or the fight response are thinking you're nuts, and you're trying to be responsible to see if you can make the best decision, when you have to accept there is no such thing as a perfect decision or a perfect action. And that the difficult part for all of us is no matter what we do, we know that we can't completely eliminate risk. We can't completely protect the population of people we're responsible for as therapists or healthcare providers, and that there's an awful lot of moving pieces. And then in the next slide, I want to ask you, how many of you are dealing with this situation where your boss wants you to return to work? You think that's wrong. Or you have friends who are teachers, and they're feeling that it's dangerous for them to go back to school. Or how many of you moved to a safer locale? You left a densely populated area to stay in a less populated area. How many of you are still ordering things online and not going into any stores? And one of the dilemmas with this is when you're stuck in this flight response is you have no opportunity to develop mastery over the situation, and you maintain a really high level of fear. And then you also avoid opportunities for living well. And that's the most important thing, is that one thing that we are all learning now is that this pandemic is going to go on for a long time, and that we have to find a balanced way to live with the new normal, where we're able to socialize, to shop, to have friendships, to have our children have friendships. And we're finding that actually it's psychologically and mentally health necessary that people have pandemic pods. And we know for sure that it's not good for children to be isolated. And we know that it's not good for us to be isolated. And we're starting to see, and Keith is going to talk about this more later, is basically we're starting to pay a high price in terms of everyone's mental health. And so if you're stuck in fight, flight, or freeze, it is not going to do you any good. So let's go to the next slide. So how many of you are finding it's hard to return to a more normal life? And I'll give you a story from my own. I remember, 5 weeks into the pandemic, all my staff and I were working from home and doing telehealth, and I was just seeing my husband, and I'm an extrovert, and I was just dying in terms of feeling cut off from people, even though I had lots and lots of Zoom contact and had no, absence of ways that I was communicating with friends. I just wasn't seeing people. And at that point, I decided I'm going to go into my office, and several of my other staff who felt like they had to escape from their children, that they just couldn't take it any longer. And I remember going in, and I'm an expert at doing exposure therapy and knowing that, and I found myself feeling anxious and nervous about seeing my staff and about the risks that were there. And we ended up hugging each other and saying hello, and that made me nervous, even though I realized I had no reason to fear that they had experienced any dangerous exposure, but it's an example of what happens with negative reinforcement. And negative reinforcement is the same thing that happens if you have a baby that cries a lot and you pick it up or feed it every time it cries. Then what you're going to get is a kid that's constantly crying, and you're going to constantly be picking them up and feeding them. And anxiety is like that tantruming child. The more you feed it, with giving into it, with fleeing, with fighting, with reassurance seeking, with trying to make sure everything's perfectly okay, the worse it gets and the more inflexible and intolerant and stuck we get in our thinking. And it means that it's going to be very, very difficult for you to find the new normal that we all need to find over the next year to 2 years. So that's something to pay attention to in your life. You know, what's happening in terms of the price you're paying for being careful, for avoiding, for staying indignant and righteous about what others aren't doing to help control the spread of the pandemic, and what cost that has to your mental wellness. So let's go to the next slide. Okay, we have here a dilemma. There are some general risk factors that are worth mentioning in the population. And I want you to think, like, how many of you have an anxious friend or an anxious coworker or boss or, anxious family members? And we know that if we look at sort of the general population risk at any one time, about 20 to 25% of the population is going to have an actual diagnosable anxiety disorder. Unfortunately, we see those statistics going up, and we believe when we look at genetic risk factors that probably around 40% of us have genetic things that predispose us to developing anxiety. And this explains why in any traumatic situation, we know that approximately 40% of people who are exposed to trauma get PTSD, and most of the people do not. And we think it's now because they probably don't have those risk factors. So what does it mean if you inherit the tendency to get anxious? Well, it means that your body and your brain can do single trial learning, where it takes just one exposure to something that's frightening to have you get a strong response and a strong desire to avoid or fight or freeze. And so that's one thing that can happen. And then the other thing we know is that if you do not have autism or more severe Asperger's disorder, then your mirror neurons in your brain make you empathize. And what's interesting is empathy isn't just a psychological event that happens. And empathy is our ability to correctly understand how others feel in a given situation and to understand how it's different than our own. What happens when we engage in empathy is we actually recreate the feeling that we see based on the subtle gestures in that person's body and face, and we mimic them. And so we actually recreate the experience of anxiety. So if we have people around us and they're feeling very anxious and frightened, then we're recreating that experience inside ourselves. And it explains one way where you can get mass panic and mass fear events happening. And then the other thing you have to understand is our brain is actually kind of stupid when it comes to emotion. It cannot distinguish between real emotion from a real situation and imagined. It's why we can enjoy a novel or a movie or ride a roller coaster and have, consider it thrilling to feel, frightened out of our mind. But the problem with that is if we're not sharp about reinterpreting what we're feeling based on the context as being normal or just imagination, then we can really get caught up in that fear. And what our brain does when we feel fear and it gets this signal from the base of the brain is it just assumes it's real, and it makes us want to take fear-based action. And we go back into that fight, flight, or freeze cycle. And it means you're going to have to learn to be careful about what you're feeling and why, and to realize, okay, is this actually necessary, or is it the context of the situation? And if it is, then do I really have to pay attention to it? Do I really have to take action, such as a negative reinforcement action, fighting, fighting, or freezing, that's going to make things worse for me? So I'm going to talk now about some specific risk factors that you can address in terms of mental wellness. So let's go to the next slide. So, how many of you saved up toilet paper or meat or poultry or paper towels or hand sanitizer or masks? I know early on before quarantine started here where I live in the Midwest, my patients were flooding Amazon with orders. They were going out and they were panicking about the fact that they just couldn't get enough. And I think they were anticipating some sort of, zombie pandemic Armageddon thing. Well, this is what happens when people have intolerance of uncertainty. And Keith is going to talk about some specific ways to address this, but I'm going to describe you is if you are one of those people where you like to make sure that everything is okay and you don't like surprises, you would rather make sure you have what it needs and play it safe, then chances are your intolerance of uncertainty is not very useful to you. It's a little higher than it ought to be. And what happens when someone dislikes uncertainty is they take a safety strategy where you go better safe than sorry. I'm going to only think about the negative things. And then because you're thinking about the negative things and your brain can't tell the difference between real or imagined danger, you feel like you've got to take some action, like buying up all those toilet paper rolls and paper towels and hand sanitizers, etc. And it's why I recently moved to a new house and I still don't have a new refrigerator because so many people bought up freezers and fridges because they're worried about a meat and poultry shortage because of the pandemic. So let's go to the next slide. So I'm going to ask you, how many of you noticed once this whole pandemic started that you were eating more junk than you normally did, or drinking more alcohol to try and relax, popping more candy, more popcorn? And then I certainly saw on social media, there was a heck of a lot of baking going on. One of the areas, this is a problem. One of the most exciting areas in my mind where we've been doing research in mental health and mental wellness is on the area of inflammation. And if you're a medical provider, inflammation has a prominent role in all kinds of diseases, including cancer. Well, the news is it also has a big role to play in mental illness. And we now know that the less diverse your gut flora are, the more inflammation you have, then the higher your anxiety and depression is going to be. We've got some very exciting research that shows when we get people on a low on the food chain diet, where we get rid of additives and we eat organic and we try to have very little quantities of meat, fish, or poultry, or none, such as a vegan diet, then over a year's course, we can get rid of the need for medication and we can get rid of depression and we can greatly decrease anxiety. And, one of the things you've got to remember, which those of you who are medical in your professional background know, is that the two fastest ways to decrease inflammation are not by taking aspirin, it's by eating a diet that is whole food, plant-based, with just small quantities of meat, low in fat, and trying to avoid all processed foods and processed oils. And then also to exercise. And so we see if you really want to be powerful in a general way to help your mental wellness, then you're going to be a regular exerciser and you're going to eat a really healthy diet. And you're not going to be one of those people that's constantly sharing sourdough bread starter. Instead, you're going to be sharing apples and kale and great lettuces that you grew in your backyard. The third thing that we know can decrease inflammation is adequate sleep. And we do see that people have been sleeping more poorly because of anxiety or because of lack of exercise, during the pandemic, or feeling that it's just not safe to go outside. And that's one of those necessary healthy risks that I'm going to urge you all to take, is to get out there and exercise. And unless your community requires it, to not wear a mask, because there's not great science that's showing that you have to wear a mask when you're exercising outdoors. Let's go to the next slide. And then just a word about professional safety. And this is something that Keith is going to address in relation to exposure, but I want to talk about it. That one of the problems that we have here is that, I'm a slide ahead of myself. I'm going to go back to the risk-taking slide, is that a lot of times I hear professionals asking, why are these college age and teenage people and young adults being so stupid and going to the beach and putting us all in jeopardy? And I want to remind you that it is normal for the adolescent brain, which usually doesn't mature until the mid-20s, to assume that they're not at risk. And so their perception of risk is very, very different than ours, than someone who's a mature adult or someone who's a young child where they'll take the word of an adult. And then we also have people who have the T factor, the thrill factor in their personality. And those are people who, they're at the other end of the scale from the anxious, neurotic folks. They're the ones who want to join the Navy SEALs, do extreme sports, and ride motorbikes on wet roads at night. And they're not going to feel risk the same. And then also we have the macho mindset. And that's where people feel like, my masculinity or my toughness as a soldier or sailor or whatever is compromised if I show that I'm concerned about safety. And so if you're having trouble addressing this with your own children or with your patients, I'm going to urge you is address their mindset and not yours, because the mistake a lot of us make is we try to sell them on the idea of better safety using our strategies. And you have to find something that they care about that matters to them in order to wear masks or to be safe, such as protecting someone they love, such as making a boss like them better, such as being a role model for children who are very vulnerable and have to wear masks. And you're going to get farther with that. So let's go to the next slide here, the professional safety side. Okay, this one where I was going back to her is, I want to just remind you of one thing. The safety that you follow in a hospital or a medical setting or a COVID unit or intensive care or the OR is not the level of safety you need to follow when you're out in public or when you're at home. And when I've been working with medical professionals, I see they're taking the protocol that they use when they're with known patients where there's a high COVID risk, and then they're trying to apply that same thing at home. So the maid comes in and they want to wear a face shield and a mask and gloves and then clean after the maid leaves and the maid's wearing a mask. I want you to remember that what you do at work isn't necessarily the thing that needs to be done at home, because at work, oftentimes you're going to have a known risk that you need to handle in a definitive way, as opposed to being in a low risk environment. And then let's talk about two strategies that I want you to think about in terms of your general wellness. So in this, I'm going to go to the, let's go to the master your fear and feeling afraid. It's one thing Keith is going to tell you about is if you can learn to not be afraid of your fear and to look at it as the false signal, your anxiety, then you've got a huge step up in life. You have a huge advantage, and you'll do me and Keith out of a job and the insurance companies and the healthcare system. And you need to remember that you don't have to perfectly get it right in order to live a safe, reasonable life, and that what you have to do is to learn to take reasonable risks and to not be afraid of getting anxious and to not assume that your fear is accurate. Let's go to the next slide. And then the last two strategies I'm going to talk about here are things that are really powerful, that are an incredible thing to add to your exposure therapy that Keith is going to talk about. So, how many of you can think of a strategy that you could do every day that could decrease inflammation, increase your dopamine, your serotonin, and your oxytocin? Those are feel-good hormones that are great for your mental wellness, and could decrease hypertension and decrease your likelihood of getting sick just by doing writing? Well, it's gratitude. There's over 15,000 studies on this, and if you want to go to the Greater Good at UC Berkeley, you can read about all the research on gratitude. It's really powerful. And mental health professionals now know it's a core character trait of mental wellness, and it's a protective factor against anxiety and depression and other mental illness. And gratitude is so powerful that something along with exercise and healthy diet that I recommend to all of my patients all the time. And so let me give you one study that ought to really pique your interest. And this was done about 15 years ago, where they had people who were depressed, and they made them write 3 things down every day that were specific to that day that they were grateful for. And at the start, they didn't have to actually feel it, just had to know, well, this is a good thing. And at the end of 30 days, they found that most of those people were able to get rid of medication, and they no longer had symptomatic depression. Well, there's been repeat studies on this done on various different disorders, and we've shown it has the similar powerful effects with anxiety. And the trick is you have to focus on specific things, preferably small ones, that happen in the moment in the day. So it's not like Thanksgiving where you pray for our nation, you know, thank you for our nation, thank you for my family. You're thinking about actual events that happened to you that you experienced. And we found that if you really want to rev this up, you think about what's good about the tough situations, like your experience in the pandemic. And this is really powerful and important. And we see that if people recover well from trauma, then they're people that oftentimes are able to think of something good that they learned from it, or that they now have an advantage in their character or their knowledge or the way they can serve the world because of this experience. And you need to do that. And so you can start a journal. We see from research that writing it down is better than keyboarding it, explaining it out loud, and trying to savor it. And so what I recommend to people is to start off with the first month, 3 times a day. And after that month, then you can skip to 3 or 4 times a week. And then that works really well. And I've been doing this for the last 13 years, and it is so helpful. The last thing I want to talk about in my last slide is good humor. So everyone here, I'm sure, has heard of the fact that if you do mindful meditation, it's incredibly good for your physical and mental health. And we know that if you laugh, you accomplish the same metabolic thing that 20 minutes of mindful meditation does. You get the same surge of dopamine and oxytocin and serotonin that you did if you did all that meditation. So this is the shortcut. And we found if you fake laugh, it actually has the same effect. So if you do that laughing yoga where you're just going ha 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 until you all start laughing, that'll help you. So here's my challenge. You're going to have to find your funny in the pandemic, and you're going to have to find the funny in your anxious response, in the anxiety of others, and you're going to have to try and amplify that. And I'm going to suggest you do the thing that I love doing with my family is we every week have competitions to find the funniest YouTube video, and we declare a topic like on hamsters or cats or toddlers singing Frozen. As a family, we don't do apocalyptic movies together. We watch funny movies. And I make a point of reading funny books along with my other books. And the other big thing is to learn to ask your coworkers and your family and friends, what's the funniest thing that happened to you today or this week? And you can sharpen your good humor. And lastly, sarcasm is not good humor. It's actually an expression of anger, and so you want to curb sarcasm. I'm talking about being able to just have a good belly laugh about the absurdity of yourself and the absurdity of our situation now as a world in the middle of pandemic. And so with that, I'm going to turn it over to Keith.
Thank you, Karen. Can everyone hear me?
Yes, you're good.
Great. So this is really cool because a lot of what Karen talked about is going to really set up some of the points that I'm going to come to in my portion of the talk, especially kind of focusing on some specific types of anxiety that we see, especially in terms of increasing difficulties, and then how those are addressed in formal treatment, especially using exposure therapy. Madeline, I think I can advance myself, but I'll let you know if I can. So first thing I wanted to do is actually just take a step back and look at just how complex and extensive the impact of this pandemic situation has on all of us, and in particular in ways that may contribute to increased anxiety. So first and foremost, we're all inherently at greater risk of developing serious and potentially fatal illness, and that's really important. Anxiety is all about perceptions of risk, and the fact that we're all at a greater risk is a factor that certainly is going to contribute to increased anxiety for most of us. But on top of that, the risk that each of us faces personally and in different situations is very uncertain, and is changing and evolving over time. So Karen talked about uncertainty, and especially intolerance of uncertainty. Uncertainty is certainly a major factor that fuels anxiety as well. Beyond that, we know that social support is a very important buffer for the effects of stress, and that the opportunities for this have significantly changed in the context of social restrictions. Likewise, many of the opportunities for the activities that we might normally partake in, especially the leisure activities that we enjoy, have changed or decreased, and that certainly has a notable and important impact on all of our moods. Many of us have experienced or may experience significant acute stressors, ranging from things like job loss to even traumatic events such as the death of loved ones. And then on top of that, there is the chronic stress, which is things in our lives have changed, including things like our work environments have changed and daily routines have changed. And those are things we have to adapt to. So in light of all this, it's not surprising at all that what we're seeing is clearly a substantial increase in anxiety symptoms for many. And this includes many more people experiencing what we might call subclinical symptoms. So they don't have a formal diagnosis, but they're certainly experiencing some of the same sort of symptoms. New onset of diagnosis, which may often be cases for individuals who were at risk, as Karen talked about, or maybe had experienced some of those problems before, but they've gotten worse or increased, and that's pushed them into having a diagnosable problem. And then certainly for people who have been suffering from anxiety problems beforehand, we often see an exacerbation or even some new symptoms for those individuals.
Hi, Keith, we lost you for a couple of seconds.
Yeah, thank you for letting me know. I wondered because all of a sudden it started popping up on my screen saying I was muted. So diagnostic consideration. So I'm going to focus on 3 diagnoses in particular, but I wanted to kind of take a broader look here. So first, the diagnosis of illness anxiety disorder is clearly one that's very relevant to this current situation, and something we're definitely seeing increases in. Second, the situation is also quite relevant to obsessive compulsive disorder, since concerns about contamination and behaviors related to that concern about contamination is a common domain of OCD. And then I'll also talk about agoraphobia in terms of differential diagnosis or determining when that's an appropriate label for a particular individual or the problem they're experiencing. And in terms of trying to work with or treat that condition during pandemic circumstances. But I also just wanted to note that the situation really has notable implications and impact on many other diagnostic problems, including generalized anxiety, panic disorder, and post-traumatic stress disorder. And if individuals you're working with have really truly only been experiencing this problem and these symptoms since the onset of the pandemic, then for those individuals, the most useful or appropriate diagnosis may be adjustment disorder, since the stressor is still ongoing. Sorry, did you lose me again? For some reason, I keep going on and off.
sometimes every time you try to advance the slides, you end up muting yourself somehow.
Yeah, that's what I was noticing too. So why don't we?
So I can advance the slides to avoid this problem.
That sounds good. Thank you. Okay, so illness and disorder. These are the diagnostic criteria. Primary one that I want to point you to is the primary criteria, or first criteria, which is preoccupation with concerns about having or developing an illness, which, as you might imagine, is something that we're certainly seeing a lot in the context of the pandemic. The second piece that's important is that that's for an individual who either has no symptoms or the anxiety is clearly out of proportion to the nature or severity of the symptoms that they are experiencing. So it's still clearly excessive in terms of their response or anxiety about the illness. And lastly, I'm going to point you to criterion D, which is that we think a very important factor that contributes to this, that we'll come back to, and also that Karen alluded to, is these health-related behaviors that can become excessive, and they're engaged in to increase or decrease the anxiety in the moment, but in the long run, unfortunately, they can maintain these fears and anxiety. Sorry about that. Madeline, you can go back.
Not sure why that keeps happening.
Yeah, my apologies. Okay, so this is, you can go back one slide to show the cognitive behavioral model of health anxiety. I'm not going to spend a lot of time on this, but just quickly to point out that how this is a problematic cycle that often begins with unhelpful thoughts or unhelpful beliefs about illness. For example, the tendency to really focus on the negative and potentially overestimate the chances that we'll get sick. The result of that for individuals is often paying a lot of attention to sensations and potential symptoms in their body. And when they notice things, then they have these excessive or catastrophic thoughts about those symptoms. That, of course, leads to a lot of anxiety, and that motivates behaviors to try to decrease that anxiety with the goal of decreasing the risk of becoming ill. These include things like doing things to avoid or reduce contamination, getting certain tests done or seeking reassurance. But the problem is that unfortunately this tends to reinforce those initial thoughts and beliefs that the individual is potentially ill or at heightened risk of becoming ill. Go for it. Shifting gears now to OCD, obsessions are defined as recurrent and intrusive thoughts that cause intense anxiety. And this includes intrusive and distressing thoughts about being contaminated and or being or becoming ill. Compulsions are defined as certain behaviors or mental acts that we engage in repeatedly with the goal of feeling less anxious or making ourselves feel more safe. And those can include things that we might do to potentially reduce our risk of becoming ill, such as those health-related behaviors just noted on the last slide. So to qualify for a diagnosis of OCD, these thoughts and behaviors have to be happening a lot. So the rule of thumb is that they have to be taking up on average 1 hour each day. And for some individuals with OCD, they take up much more time. Finally, in relation to agoraphobia, what you'll notice the first criteria is person experiences marked fear and anxiety about these types of situations. So examples would be being on public transportation, being in enclosed places, standing in a line. But importantly, I want to highlight the second criteria, which is the reason that this person experiences that fear and anxiety in those situations is that the individual is afraid that escape will be difficult if they have a panic or experiencing panic symptoms. So in essence, agoraphobia is about fear of having panic attacks in certain situations. So many people might feel afraid in those situations that are listed above, but for different reasons, and those people wouldn't be considered to have agoraphobia. But of course, many people are still struggling with agoraphobia as well as panic attacks during this time, including some that may be triggered by anxiety related to the pandemic, So one of the key questions is, how can we work with and treat those individuals in these circumstances? So what I'm going to focus on for the rest of my time is doing exposure therapy during the pandemic. So this is a primary specialization of the center that I work at and the focus of a lot of my own clinical work. And how do we approach that? So first, in terms of practical considerations, there's obviously many of them. So first, we have to take into consideration formal restrictions as well as recommendations. So as a result, there's many activities or situations that we may have otherwise selected as potentially useful exposure exercises that simply aren't options. Secondly, a lot of therapy is currently being done via telehealth, including all of my clinical work at this time. So we have to consider what's feasible in that modality. And I'm happy to talk about this more, but in brief, I think most of the types of therapy and exposures that we do can work very well, if not just as well, in this format. And of course, there's safety considerations and restrictions. But to me, the rule of thumb that we've always used in terms of designing exposures really hasn't changed here. So we've always selected exposure exercises based on our perception of the risk that those things could entail, and always selecting things that we think are very low risk, considering both the likelihood that the fear may be realized and how serious it would be. So we may be comfortable doing certain social exposures if somebody's fear is somebody saying something mean to them, with the perception that that may actually happen, but it wouldn't be quite as serious if it did. When we're talking about a fear of something like a serious illness or death, obviously that's something that we're really not going to take any risk in terms of that happening. Sorry, can you go back to the last slide? Thanks, sorry. So in terms of safety considerations, so it's important to note just that simply some exposures simply aren't sufficiently safe right now. But one of the things that I always note with my clients is that's okay, because arguably, even if the people you're working with were avoiding those situations in the past, they probably aren't now because they really don't have the option to do it. So it's something that they can address once those things become an option moving forward. You can go forward. So getting into the details in terms of how we do exposure therapy, there are 3 general types of exposure which can be helpful to consider in the context of these constraints I was just mentioning. First, in vivo exposure involves doing things in real life. And so this is where those safety and practical considerations really come into play. The key is that we want to select exercises that we think are and are confident are safe, but at the same time will still be effective. So we wouldn't, if we're working somebody with agoraphobia, encourage them to do an exposure involving being on a crowded subway, but it may still be an effective and also safe exposure for that person to be in an elevator by themselves, for example. So we want to pick things that are still safe, but also will really get at the thing that they're afraid of. The second type of exposure is called imaginal exposure, which involves repeatedly imagining a fear coming true. This is, of course, an important and valuable in many types of exposure therapy protocols, but it's especially salient one now. And it goes back to something that Karen hit on that's really important, which is the strength of our imagination in terms of bringing on different emotions, including fear and anxiety. So here we're actually leveraging that tendency in terms of doing exposure therapy to situations that either aren't feasible or aren't appropriate or both. And the way we can think about it is just there are more situations that fit that description now, and we can always consider trying to address them using imaginal exposure. The third general type of exposure is called interoceptive exposure, which involves doing exercises to intentionally bring on some symptoms. Those could be bringing on symptoms of anxiety, bringing on potentially perceived symptoms of illness, or both. So this has always been an important part of treating certain anxiety problems, such as panic. but also potentially is really useful and important for individuals working with health-related anxiety or illness anxiety. Can go forward. So how do we start and plan for doing exposure therapy? So one of the first things we do is discuss the basic theory behind the learning principles that can lead to the development of these anxiety symptoms, but in particular, focusing on the role of something Karen also discussed really nicely, which is how avoidance creates this phenomenon of negative reinforcement and unfortunately reinforces the feelings that we're experiencing in terms of anxiety and fear in these situations. Then we discuss how exposure therapy can really be used to address that, discussing not only the general rationale for exposure, but also those specific types of exposure that I just went through. One of the important points, sorry, you can go back. One of the important points that I want to highlight here is that sometimes we look at exposure therapy as a way to address irrational fears, but I think that that's really a misnomer. In any case, when somebody has a fear or anxiety about a situation, there's always the possibility that it can become excessive. And so it doesn't mean it has no base or that there's no objective risk. It just means if this problem and our reactions to this problem has become excessive, then we can potentially try to scale that back using exposure therapy. So once we've introduced the rationale behind it, then we generate ideas for types of exposures that might be helpful. And what we do is generate what we call an exposure hierarchy, where we develop a list of possible exposure exercises and usually arrange them in terms of order of difficulty. So some helpful questions to ask to think of potentially useful exposures include: what triggers your anxiety? What situations or activities are you avoiding? Very importantly, why are you avoiding those situations? Or what are you afraid might happen? And of course, we're taking carefully into consideration any practical constraints. The reality is that there's always been practical constraints in terms of what we can do, and those have simply changed now. But we're not just kind of taking those things off the table. We're thinking creatively about how we might still do an exposure related to that particular situation that the person is either avoiding or afraid of. Can you go forward now? Can I advance the slide now? The last topic I'm going to talk about is the flip side of exposure therapy, which is what we call response prevention. And this is a very important part of many exposure therapy protocols. But taking a step back from that, we think it's generally very important when you do exposure to address anything that could possibly be conceptualized as a safety behavior or something that makes us feel more safe when we start to feel anxious, if that's happening during or after an exposure, because we think that that's going to undermine learning and make that exposure really not as helpful or not helpful at all. So an example might be if somebody does an exposure where they're exposing themselves to a potential source of contamination, and then during or afterwards they're using hand sanitizer or washing their hands, then that really may take away the benefit of that, because they may simply perceive, well, the only reason nothing bad happened or the only reason I didn't get sick is because I did that. So when treating conditions where these behaviors are thought to be a central part of the problem, such as OCD and illness anxiety disorder, it's really important to have a formal plan of what sort of behaviors we're trying to cut down or stop altogether. So when we work with clients, especially clients who come to us for treatment of OCD, many of them have done exposure therapy before, but they really weren't paying careful attention to the response prevention side. Go forward. As the last slide that I'm going to have before we open it up for questions. So thinking about health-related safety behaviors or potential compulsive behaviors, what do we need to pay attention to and what might need to be addressed? So the first category is what I usually call approach behaviors, because they involve actively doing things. These include things like searching for or reading information, calling doctors or getting tests done, seeking reassurance from other people. Second category involves avoidance behaviors, such as not getting tests done or not attending appointments, avoiding certain places and situations that might seem risky, such as healthcare settings. And these might seem on the surface like they're in conflict or the opposite, but really the underlying motivation is the same. or to reduce the risk of potential contamination or illness. So how do we identify the sorts of health-related behaviors that are relevant to a particular individual? So one is that once they know what to look for, they can keep track of these things as they experience them or monitor those behaviors in their day-to-day lives. You can also more pointedly ask, what do you do? What do you normally do when you start to feel anxious about this? Or the flip side, what would make you anxious if you didn't do that? Last but most importantly, especially in this current situation, is how do we figure out what is understandable versus what is excessive? Especially given that many of these sorts of behaviors have understandably increased for many, if not most of us. So first thing we really want to consider is using normative comparisons, not only comparing the things we're doing to our peers, but also comparing to formal recommendations. So what does the CDC recommend? Or what does your employer recommend in regards to particular behaviors? Second, we really want to consider the impact that that behavior is having on the individual in their lives. If it's taking up a lot of their time, getting in the way of things that are important to them, then it's certainly something that they may want to consider at least reducing. So I will end there since we're running short on time.
Thank you so much, both, for such engaging presentations. One of the first questions that we got was about how to start with clients that are so fearful that they're too scared to start an exposure therapy.
Well, how about I'll take a first stab and I'll let Keith round it up. I think the first thing that you need to do is to find what's a small ask that you can make of the patient. And the mistake that a lot of people make is they're asking too much. And so when someone, when I suggest what I think is a small step and the patient looks at me and says no, then I ask them, okay, what would be a half step or a quarter step that you would be willing to take toward that? And so that can be helpful. And then the other thing that can be very helpful with someone like this is to clarify their motivation for why they're trying to do the treatment. And that can be where you can try and get them to remember, how good it felt when they weren't so scared. Or this wasn't such a predominant thing, and how good it would feel to get there, and to remind them that all the things you've been doing with your avoidance, with your reassurance seeking, with your you name it, has been making it worse. And so what about trying this? And then the last thing I try is to say, let's do an experiment. You don't have to commit to this treatment. If you could just try it today, and see what happens and whether or not you can tolerate it. Because part of what we're teaching people with exposure is that you can manage and tolerate your anxiety and the situation, as well as that your anxiety will go down eventually. Yeah, Keith, what can you add to that?
I can't add anything because that's exactly what I was going to say. So the 2 points I want to just reinforce or highlight is whatever they're willing to do as a first step, as long as it's a step in the right direction in terms of challenging themselves, and it will make them anxious, is great, and that's where to start. And also, I sometimes will make sure that they do understand the rationale for exposure treatment and how we think it'll be helpful, because that sometimes can be something that is getting in the way or preventing somebody from taking that first step.
Great, thank you. Another question was how you can treat agoraphobia or OCD or germaphobia when there's a confounding anxiety disorder. And so it's not just one type of anxiety that someone's experiencing, but they have so many different facets to their anxiety.
Yeah, Keith, why don't you go first on that one?
Sounds great. I have 2 general recommendations of ways to go. If there's a number of different diagnoses, including different types of anxiety going on, which is very common, more common than it is not the case. First is you can choose a treatment protocol that's less diagnostic specific and more transdiagnostic. There are a number of them out there, including a number that have been really well tested and studied and shown to be helpful. So for example, there are some more transdiagnostic interventions focused on managing all sorts of different emotional difficulties or disorders. And then there's also some more transdiagnostic protocols that are focused on phenomena such as perfectionism and intolerance of uncertainty that really do cut across different diagnoses. So you can go the transdiagnostic route. The other route that you can go is really starting off and saying, where do we want to start? There's a number of things going on, but let's pick what is kind of the highest priority for you. And then trying to really focus on that. So we have a lot of OCD cases where they have other things going on, but we start off really focusing just on treating OCD, with the idea being if we can really make a substantial dent in that, not only will that have a significant impact on their lives, but we may also see some indirect benefits on those other problems.
And one thing I would add is that it's helpful if you remember that, 70 to even 80% of people, depending on the study, who have one anxiety disorder will have two or more. And so when we're treating them, the separate categories are useful in terms of thinking about clusters of symptoms, but it doesn't matter that much in terms of treatment as long as you know the phenomena of each disorder, because regardless of the disorder, you're always teaching someone two important things. And one is I can become the master of my anxiety, and I can learn to disregard the false fear signal that I'm getting, and I can handle the anxiety, and in fact, I can overcome it and it will go away if I face it, and if I learn to selectively focus on things other than my fear. And so, it's probably rare for Keith, and it's certainly rare for me and my staff to get someone that has just one. And so just like Keith, we go on, okay, what's the thing that's interrupting the most? And then we keep going down the list, regardless of under which diagnostic category it goes. And we're just using the same principles of exposure, the response prevention, and then trying to develop those habits of mental wellness that I was talking about in terms of good humor, gratitude, optimism, grittiness, those kinds of things.
Great, thank you so much. That's all the time that we have for today. As a reminder, the slides and recording will be sent out to all registrants, and we will include in that information on how to receive a certificate of attendance. Thank you.
Thank you.
Thanks, everyone.